If you're a physical therapist, an OT, or an SLP, you know that staying in-network is, well, it's everything, especially with a major payer like Cigna.
It's mission critical for your cash flow.
Exactly. But what happens when Cigna decides to uh, outsource that whole relationship for specialty services to another company? A company you might not know as well, like American Specialty Health, or ASH.
Well, that's when things get complicated. That one decision completely changes who manages your professional life. It really um, alters the entire operational landscape.
So this isn't just about a new mailing address for claims.
Oh, not at all. It's a full contractual delegation. We're talking about who manages your network status, who processes your claims, your credentialing, and crucially, who does the utilization review for, thousands of Cigna members.
Our mission today is to give you the shortcut, to really get why this Cigna and ASH delegation isn't just some minor update, but a fundamental pivot in how you have to operate.
Right. It creates a whole new checklist. And if you miss just one thing on that list, you're going to see denials, even for a patient holding a Cigna card who you know should be covered.
Okay, let's unpack this.
So the foundation here is it's a contract. Cigna has delegated certain services to ASH, which then acts as a third-party administrator, a TPA, for specific plans in certain states.
Like a landlord hiring a property manager.
That's a perfect analogy. Cigna is the landlord, but ASH is the one you call when the sink is broken. They handle all the day-to-day stuff.
And what exactly is that day-to-day stuff? Because specialty services can feel a little vague, but for therapists, this is the core of the business.
It really is. The delegation is pretty comprehensive. ASH takes over network management, all the credentialing and re-credentialing, contract admin, and the entire utilization management, or M process.
So they're the ones deciding on medical necessity.
They are. And that means they also handle the prior authorizations, the PAs, and then the actual claims processing on the back end for these services.
So just to be clear, if a patient walks in with a Cigna card, but they're on one of these delegated plans, I'm not dealing with Cigna anymore for a PA request.
Right.
I'm dealing only with ASH.
That is the practical outcome, yes. And what's really fascinating here is how dynamic this all is. The states involved, the CPT codes, the specific Cigna plan type, it can all change.
It's a moving target.
It is. Providers have to constantly watch for these phased expansions. What Cigna managed last year might be ASH's job this year.
So the bottom line for our listener, the provider, is a huge redirection of all their administrative traffic. Your enrollment, your PA workflows, how you submit documents, your appeals, it's all going through ASH now. Different forms, different portals, different phone numbers.
A whole new system to learn.
Which brings us to the 4 huge operational shifts this creates for a practice. I mean, this is where it gets really interesting and frankly a little scary.
The first, and I think the most dangerous area, is credentialing and network status.
Yeah.
So many providers assume, I'm credentialed with Cigna, so I'm good. But if ASH is managing that network for that product, that assumption is it's false. You have to apply directly to ASH to stay in network for those specific members.
Wow. That sounds like a minefield. You could be treating a Cigna member, thinking you're in network, submit the claim, and then just get a flat denial because you missed this one separate paperwork step.
That risk is very, very real. We see it happen all the time, especially during these rollouts. It forces you to maintain 2 completely separate administrative relationships just to see the same patient population.
Okay, so if that's hurdle number 1, the second has to be about actually getting paid, utilization management and prior authorization. How is ASH's approach different from Cigna's?
Well, their reviews can introduce new and sometimes, frankly, more restrictive PA requirements. They might have their own documentation templates or really explicit limits on an episode of care that you don't see in other Cigna plans.
Yeah, that just means more time on the phone.
It's more administrative load, period. It's not just an academic thing. It's you spending an extra hour every single day fighting for approvals instead of actually treating your patients.
And that fight leads right into the third major shift, which is documentation expectations. Why does the paperwork become so high stakes here?
It's high stakes because these delegated vendors, they often lean really heavily on their own internal checklists and algorithms to review for medical necessity. So a successful claim doesn't just hinge on, good clinical practice. It hinges on whether your documentation specifically checks every single box that their vendor requires.
Can you give us an example, like clinical best practice versus their checklist?
Absolutely. A therapist might write in their notes that the patient has improved functional mobility. Clinically, that's accurate, it's meaningful, but the ASH review criteria might specifically demand a number, like an increase in 10-meter walk test speed by 2 seconds.
Ah, hard metric.
A hard, quantifiable metric, or maybe a reduction in the Oswestry Disability Index by 10 points. If your note doesn't have that specific data point, even if the patient is clearly getting better, they can deny the claim.
So the medical record becomes a compliance document first and a clinical tool second. You're writing it to satisfy an algorithm, not just for continuity of care.
Precisely. And that leads us to the fourth shift, appeals and escalation. When that denial comes through, even though it's technically from Cigna, the appeal has to go back through ASH.
Wait a second. So if ASH made the initial denial and they also handle the first appeal, doesn't that feel like a conflict of interest? They're basically grading their own homework.
That is the systemic conflict that policymakers are looking at more and more. But for the provider, the immediate problem is just procedural. The address you send it to, the timelines, they can be totally different from Cigna's standard process. If you send that appeal to the wrong place or miss the deadline by 1 day, it's over. You lose your chance to reverse it.
So you have to map it all out beforehand.
You have to.
It really sounds like running a practice now means juggling 5 different rule books depending on the patient's plan. And that's where this whole conversation gets bigger, right? It's about that tension between controlling costs and making sure patients can actually get care.
That tension is the absolute heart of the debate. I mean, when it's done well and it's evidence-based, sure, it can cut down on unnecessary services. That's the goal. But the other side of that coin is that these heavy PA systems, especially when they're not transparent, create so much administrative friction.
And friction means delays. And delays mean patients might just give up or get worse while they're waiting for paperwork to clear.
Exactly. When the burden on the provider gets too high, it becomes a real barrier to access. It's not just an annoyance for the clinic, it's a legitimate public health issue. That's why you see regulators, CMS, and groups like MedPAC taking a much harder look at how these TPAs operate.
They're trying to figure out if these systems are actually promoting quality care or just putting up roadblocks.
Right. Are they quality tools or just cost barriers?
Okay, let's get really practical for everyone listening. Shifting gears here, what are the absolute non-negotiable questions a provider should be asking right now?
Okay, first, you have to do your homework. You need to confirm. Is my specialty PT, OT, or SLP actually included in this ASH delegation in my state for the specific Cigna plans I see?
And where do you find that?
You start with your signed Cigna contract and any updates they've sent. These rollouts are usually announced in letters or portal messages.
And if the answer is yes, you're in a delegated state, what's next?
Next is network stability. You have to ask, what exact credentialing application and recredentialing schedule does ASH require? Don't just assume it's the same as Cigna. You might need to start a whole new application with ASH immediately.
And if you're not sure, just call them.
Call their provider relations line and get the call ID and the rep's name. Document everything.
Okay, so once you're credentialed, the daily fight is getting the visits approved. That means knowing their documentation rules inside and out.
That's the third question. Which CPT codes need a PA through ASH, and what specific evidence do they expect? Are they looking for quantitative measures, certain functional scales, specific frequency limits? Ask for their clinical guidelines in writing.
Don't just accept we follow industry standards.
Never. If you don't know their specific checklist, you can't prove you're following it.
And finally, the emergency exit. What happens when you get a denial?
The fourth question is procedural. Where exactly do I send an appeal? What are the hard deadlines and the routing rules? You need the physical address, the right payer ID for ASH. Sending it to the wrong office is an automatic rejection. They won't forward it for you.
Okay, let's dig into some of the nuances here, because the enrollment piece seems to cause the most confusion. If Cigna delegates credentialing to ASH, is it really just a one-stop shop?
That's a great question, and no, it's often not that simple. It's very product dependent. For some Cigna plans, yes, getting credentialed with ASH is all you need. You're in-network. But for other plans, say a specific Medicare Advantage product, you might still need to maintain a completely separate, up-to-date file directly with Cigna's own system.
So if you have a mixed patient panel, you're doing double the work.
You are likely maintaining 2 or more files at the same time, yes.
And what about the contract itself? Are the terms from ASH identical to a Cigna contract?
That's another big no, and it's a crucial FAQ. Delegated vendors like ASH can and do impose their own specific requirements.
Like what?
It could be anything. Hire malpractice insurance limits, different termination clauses, unique financial rules. You have to read the actual ASH network agreement for your specialty. You can't just assume it mirrors the Cigna one.
Okay, let's circle back to clinical criteria. You said to ask for their guidelines. What if they're vague and just say, oh, we follow evidence-based standards?
That is not enough. You have to push for the specific published document or internal policy that they use for a specific condition. You need to be able to say, I am appealing this denial for code 97110, and I am referencing your own clinical policy document version 2.3 on page 4.
You have to use their own rules against them.
That is the only way you can demonstrate compliance, which is what the entire review is based on.
And what about telehealth? That has to add another layer of chaos to all this.
Oh, telehealth is probably the most complicated piece of all. The policies for billing, where the patient is, where the provider is, it all differs wildly by product, and it's all tangled up in state laws.
So what's the checklist for that?
If you're offering virtual care, you need a detailed checklist from ASH. Which codes do they cover for telehealth? In which states? Does the therapist's location have to be credentialed? Does the patient's? It all needs to be confirmed in writing.
So we've covered the big operational shifts, the policy context, and the admin steps. It all just comes down to managing an insane amount of complexity.
The final practical summary is this. The providers who succeed are the ones who treat the Cigna-X relationship as two totally distinct paths. You have to track your ASH approvals, your ASH denials, and follow their timelines to the letter. It's the only way to keep your revenue flowing and stay in network.
So what does this all mean? I think the core insight here is that this delegation to ASH fundamentally changes the game for PTs, OTs, and SLPs. You're not just dealing with Cigna anymore. You're dealing with two separate, highly specialized administrative systems that demand their own unique checklists.
Right. You have to run a parallel operational playbook. And looking forward, as these delegated models become more common, it really raises a big question for you, the provider, to think about. Given the administrative burden and the care delays we know can happen with these systems, how can you proactively engage with your state's Department of Insurance or other policy groups to push for more transparency and efficiency in these delegated contracts? How do we make sure that the balance between cost control and patient access stays, equitable and functional for everyone?
A vital question for the health of both patients and practices. Thank you for joining us for this crucial deep dive. We'll see you next time.